Well, good morning, everyone. This is, I think, the inaugural 2024 season of our Global Neurosciences Grand Round lecture series. And it's really, really wonderful for us to start off with my friend, Tina Loven. Um, I'll just, I know that Dr. Loven has a lot of content that she wants to get through, so I won't bore you with too much of a large preamble, an introduction. But I do want to say that I've known Tina for the last 5 years, and we've been partners in crime, manning the outpost at St. Christopher's Hospital for kids. And I can't imagine a better person to do that with. We've seen, and today she's going to talk about pediatric neurosurgical emergencies, and we've seen a wide range of things, maybe not surprisingly, as Philadelphia is a rough and tumble city. We've seen things from tumors to traumas, and I can't think of a better person to have the dedication, passion, and expertise to get through those cases and help those children. Some of you may, or many of you may not know that Tina is a Finnish native. She had a strong hankering for wanting to be in a NATO country, and so found herself in Queens, New York in the early 90s. She had a meandering course towards neurosurgery, but ultimately went to the program at North Shore, which is now, I think, Northwell. And then after that, she culminated her neurosurgery training with a really, really high-powered fellowship at Stanford, Lucille Packard's Children's Hospital out in California. She joined Global Neurosciences, I think it was at the same time that I did in 2019, and has been just a real source of inspiration for me in all those years. Today, she's going to talk to us about pediatric neurosurgical emergencies. And Tina, before she gets started, I just want to say she's, I think, one of the few people that I know who's a neurosurgeon that is also a NCAA noted athlete. So without much further ado, I'm going to give you your 1995 NCAA épée fencing champion, Tina Loven, to talk to us about pediatric neurosurgical emergencies.
Thank
Tina,
you.
all yours.
Thank you, Atom. I can always count on you to embarrass me. But yeah, I'm delighted to speak to you guys today about the cases that we see here at St. Chris. And Atom knows most of these cases. We've pretty much done all of the bigger cases here together, and we've seen some interesting things. So I am going to try to share my screen now to get to the presentation. Can you all see my screen?
I certainly can.
Okay, great. So pediatric neurosurgical emergencies is our topic this morning. And first, let's define what is a pediatric neurosurgical emergency. So anything that is a threat to neurological function that can range from a trauma or any kind of other pathological process such as a stroke, hemorrhage, infection, hydrocephalus, if the brain plumbing gets clogged up, that can cause a havoc, and any type of lesions, tumors, infections, disc herniations, fractures. So a lot of the most common pediatric problems that we see is centered around the brain plumbing. So hydrocephalus can present in different ways. In the very young children, where the growth plates of the skull have not been fused yet, the presentation can be a little bit less dramatic. And what we start seeing is rapidly enlarging head circumference. So we get calls from pediatricians saying the head's getting big. They also can manifest with poor head control. We can see splaying fontanelle, splaying sutures, and also engorgement and enlargement of the scalp veins. We can start seeing neurological symptoms. We can see cranial nerve palsies, especially inability to look upwards. And that's a patient of mine here with a really pretty dramatic setting sun sign where the baby can't look up. Sixth nerve is very vulnerable because he has a long course in the cranium. So sixth nerve palsy is also very common, so you can't look to the sides. In the very more severe cases in the babies, you start seeing irregular respirations. You can see episodes of apnea and bradycardia. In older children, when the sutures have closed and the cranium is now a closed compartment, the presentation can be sometimes pretty dramatic if it's an acute presentation of hydrocephalus. But you can start seeing headaches. When children are verbal, they can start complaining that their head hurts. Commonly, you see headaches in the mornings, sometimes nausea, vomiting, gait changes, and on an eye exam, you can observe papilledema, so you can see the optic nerve is swollen. This is a picture. This is an MRI with FLAIR imaging, and here you can see pretty dramatically how the edges of the ventricles are starting to show this increased signal. So this is called transependymal flow, and this is very helpful because sometimes we see patients who have large ventricles, but there's no progressive hydrocephalus. So the process has happened at one point, but now has stopped. So that's called arrested hydrocephalus. But in this case, you can see clearly that there's fluid that's pushing out of the ventricle. So this is concerning for more of an acute process. So in congenital hydrocephalus, the course is a little bit less dramatic, and the symptoms are also less dramatic. And you see increase in head circumference. You can see the babies are not feeding well. They have cranial nerve inability to look up. But in a very acute case, such as I think the most dramatic presentation for an acute hydrocephalus is when there's a bleeding to the ventricles, when there's an acute obstruction. Also, in somebody who's shunt dependent, if their shunt completely occludes and stops working, the patient gets very sick very quickly, and it can be life-threatening. So in these cases, we always get very nervous. And there's a saying that don't ever let a sun set on a shunt. So if this happens in the middle of the night, it gets us very nervous if there's an unknown patient who has a shunt obstruction, because they can literally die from an obstructed shunt. So acute hydrocephalus or VP shunt malfunction is most of the time a neurosurgical emergency. So it always warrants a call to a neurosurgeon if this is something that you encounter in the emergency room. So there's a couple of examples of what we saw recently. So there was a 13-month-old baby who was found by the parents unresponsive at home. There was no past medical history, no significant past medical history or birth history. Full-term baby, found unresponsive, last seen normal several hours before. Upon the arrival to the hospital, the baby was in pretty bad shape, was not really doing anything. Glasgow Coma Scale 3, so was not opening their eyes, was not moving, and was emergently intubated in the emergency room and transported to the CT scanner. This is what the CT looked like. So there's a coronal view where you can see that the ventricles are a little bit larger than you'd expect. But the most dramatic part of this scan is the hypodense areas here in the cerebellum. And in this axial cut, you can see that it pretty much is the entire cerebellum that's dark. So when do you see dark cerebellum? So there's some kind of massive edema, and infarcts look like this. So we wanted to get a better picture on what's going on, but we didn't want to put the baby in an MRI scanner without treating the hydrocephalus emergently. So a ventricular drain was inserted at bedside, and we wanted to get a picture of the vessels as well. So we ordered an immediate MRI and an MRA scanner. And this is what the scan shows. So you can see here that in the diffusion weight imaging and the ADC map, this looks like a massive stroke. However, when you look at the vessels, everything is open. So what the heck is going on here? Obviously, the brainstem is in trouble here. You can see that there's really no space. The aqueduct is completely closed. Now, this is I think this is the tip of the ventricular drain. So we've treated the hydrocephalus, but something more needs to be done. Otherwise, this baby is in trouble. So the baby went for emergency decompression of the posterior fossa. And around the same time as we were in the OR, the lab work came back positive for fentanyl ingestion. So there's unfortunate new things happening with the fentanyl epidemic that doesn't spare the young ones. This child had somehow gotten their hands on fentanyl and overdosed pretty quickly. And you don't need a lot of fentanyl to suffer an overdose if you are a 6 kilo human. So why does this happen? So infant cerebellums have many more, almost twice as many opioid receptors and greater opioid binding capacity as adults. So they are specifically sensitive to have this kind of cerebellar injury from opioids. And it's not just fentanyl, it can be another opioid overdose, also ketamine. We've seen this happen with ketamine as well. And it affects the mitochondrial ATP synthesis, leading to quick cell death and massive edema. It's very similar to, but not the same as what is seen in adults. There's a syndrome called chasing the dragon in people who inhale, who smoke heroin. That has a similar kind of mechanism, but it also has a component of hypoxia. In this pediatric opioid-associated neurotoxicity syndrome, anoxia is an unlikely mechanism, as the cerebellum is usually the last structure to be affected in hypoxic ischemic encephalopathy. Also, the deep gray nuclei are spared. So the only area that gets affected is the cerebellum. And despite the significant structural damage that you see in this case and on some of the other cases that we've seen, the recovery if the brainstem compression is not too lengthy and it's treated promptly is pretty remarkable, which is another demonstration of compensation of neuroplasticity in the very young patients. So this is an MRI about, I would say this is like 9-10 months after the incident. And this baby is now 2 years old and walking and talking. And actually the grandparent who now takes care of the baby was telling us that she's using the 5-year-old sister's scooter without a problem. So that's pretty remarkable. This is another patient who presented with a couple of months of morning headaches. It resolved when the day went on, and also had a few episodes of vomiting, specifically in the mornings. But not until on Christmas Day, the family was visiting Rockefeller Center Tree, and the father noticed that the daughter was walking like a drunkard and said, "Hey, what's going on?" Contacted the pediatrician, who rightly so ordered a scan, and this is what you see here. So this is a pretty dramatic presentation of hydrocephalus. And if this happened overnight, you would be in a coma. But this is a long-standing process that has been probably going on for years. And you see this really dramatic presentation of hydrocephalus. And why does this patient have hydrocephalus? So obviously, there's something here in the posterior fossa, pressing on all the structures that allow the spinal fluid to flow. So the aqueduct is completely closed. So again, the treatment for this is treating the hydrocephalus first and then trying to figure out what's going on. So this patient had a ventricular drain placed, and then an MRI that showed this large snowball here in the back of the head, about 6 by 6 centimeter in size, taking the entire cerebellum. So patient underwent a subsequent craniotomy and resection of the tumor. In about 20 to 30% of the cases for posterior fossa tumors, the CSF system does not start working properly afterwards, and the patient requires a further diversion of the spinal fluid. And in this case, we were trying to wean the patient off the ventricular drain, and she did not tolerate it. So we placed a VP shunt. Final diagnosis was a fairly happy one. This was a benign tumor, pilocytic astrocytoma. So this is all that this child needed: total resection of the tumor and a VP shunt, but no subsequent treatment, just follow-up. Now, switching gears a little bit. So this is a child that came to the emergency room, had increasing headaches, and this large lump in the forehead, forehead swelling. Again, not super dramatic presentation, but once this appeared, the parents brought him right in. Patient has a history of cystic fibrosis and also has been suffering from chronic sinusitis. So this is the scan that was obtained. This is an MRI scan that shows concerning findings. So this is pretty pretty much an infection until proven otherwise. And this looks like it all started from sinusitis and formed this big horn here. This is actually called Pott's puffy tumor. And it is a relatively rare entity. However, at St. Chris, we see 3 or 4 cases a year. When I was a resident, I think I saw one of these, but for some reason, in this demographic, we've seen quite a few of these, and it always happened to come around either early or late winter. So this is an abscess that had formed, and it's all epidural, but a pretty significant compression. So the patient went for a craniotomy, frontal craniotomy, and evacuation of the abscess. Treatment with antibiotics about 4 to 6 weeks, and did very well. So brain abscesses, they are also something that gets us nervous. So any kind of brain abscess is a neurosurgical emergency, or at least urgent, depending on the neurological status of the patient. The median age that they occur in children is between 4 and 7 years. Main cause is meningitis, but we also see infections from middle ear infections, sinusitis, and dental infections. It's oftentimes continuous spread from the primary infection, and any kind of immunocompromised status makes the patient more vulnerable for an abscess forming in the brain. Most of the cases become symptomatic within 2 weeks. So there's progression of the abscess. The early cerebritis starts within the first 3 days. Capsule starts forming between 10 and 14 days, and then a pretty thick capsule forms after the 14 days. And they can be multiple, or they can be isolated. The treatment, the classic triad is usually headache, fevers, neurological signs can be localizing. So if there's any type of personality changes, disinhibition, you're thinking that this is something that's maybe affecting the frontal lobe. If there's ataxia, abnormal eye movements, cerebellum, cranial neuropathies, paresis, brainstem can be also affected. The imaging for workup for this. So usually the gold standard imaging is an MRI with and without contrast, and you'd see a ring enhancing lesion. That's classic what you see. And the DWI is a very helpful sequence, and especially with the ring enhancing deep lesions, you can differentiate a tumor from an infection with the DWI imaging. Tumor would appear dark, and infection would appear bright. The goal of surgery and treating these is to obtain cultures and initiate prompt treatment with broad spectrum antibiotics. The medical management can be either conservative for very small infections, or surgical for anything that's causing a mass effect, or anything that's a little bit larger. Steroid use is controversial. It may help with extensive edema, but it's also immunosuppressant. And depending on the area of the brain affected, we use seizure prophylaxis. Antibiotic treatment is pretty lengthy. It's usually IV antibiotics, 4 to 6 weeks, and follow-up imaging until everything's completely resolved. Most of the time, the surgical management includes a craniotomy if it's close to if the abscess is epidural, subdural, close to the surface, or if it's in the posterior fossa. If the lesions are deep, stereotactic aspiration or endoscopic assisted aspiration is the treatment of choice. Now, switching gears a little bit. So this is a patient that came to the emergency room. So a 15-year-old girl with several days of decreased sensation to the legs and also a complaint of back pain. Had a long car trip, couple hours, and started complaining that the legs were getting number and pain was getting worse. So dad brought her to the emergency room. Past medical history, so no significant medical history, but she did have a recent death of her mother, and she was dealing with grief, and dad thought that she was also depressed. She had significant weight loss. However, her eating patterns had not changed much. And when the patient presented to the emergency room, the team initially thought that this might be a conversion disorder. So we'll talk about what conversion disorders are in a bit, but conversion disorder is the last diagnosis that you'd consider. So you want to rule everything else out before, and not until this patient was trying to transfer from the stretcher onto a wheelchair and fell for scan that it was really concerning, and she was rushed over to a CAT scan. And you can see the CAT scan here revealed something right around, this is 5-4, at L2-3 region, where the bone had disintegrated and something else was taking its place. So an emergent MRI was ordered, and we saw this. Patient at this point on exam had a sensory level at an iliac crest, was unable to move lower extremities, and bladder was distended. So Foley was inserted, and the patient underwent an emergent posterior decompression first with some screws and rods here, and then a subsequent anterior vertebral body resection and insertion of a cage in place of those deceased vertebral bodies. And the pathology ended up being Ewing sarcoma. So what was happening here? So this patient had severe compression at the level of the conus. So what can cause presentation such as hers? Obviously a tumor, but also infections, trauma, sometimes very bad disc herniations. Also, we've seen tethered cord syndromes that progress and can cause ischemia of the conus. Conus is a little bit different presentation than when the lower part of the lumbar spine gets affected. So with the lower part of the lumbar spine, we talk about Cauda-Equina syndrome. That's when the actual lower motor neurons are compressed, and the presentation is a little bit different. So there's a helpful chart here that sort of differentiates between the two. So in the syndromes that affect the conus, the presentation is a little bit more sudden, and it's usually more symmetrical. The pain is less severe, but you have more dramatic issues with the bladder. And in the coda equina, where it's more lower motor neuron, it can be unilateral, and it's a little bit more gradual. Pain is also usually a little bit more severe. So how do we work this up? Just like in this one, we most of the time in the emergency room, the initial workup includes a CAT scan, but to assess this, the best is usually with an MRI. And if you're suspicious of process like this one with a tumor, you want to get it with and without contrast. Bladder scan, if there's any concern about urination, sometimes they can be overflow incontinence that can say, hey, yeah, the patient's peeing, but it's really not peeing. They just leaking because they can't empty their bladder properly. So the pee's coming out, but it's not really emptying their bladder. So to protect the kidneys and the bladder, Foley needs to be inserted emergently. And obviously, neurosurgeon should be called. So there's this system, the Asia impairment scale, that we use to communicate with each other to discuss what is the neurological status. So complete plegia and sensory deficit would be an Asia A, and you'd have a normal patient with the Asia E impairment scale. Also different clinical syndromes. So anything that affects the spinal cord itself is pretty straightforward. So you'll have a sensory level, you'll have a neurological deficit, but there's syndromes that can be affecting just parts of the cord. Central cord syndrome is classic for an older person with a flexion extension injury. It's not really in a pediatric world. We don't see a lot of this, but this would be a cape-like sensory loss in the arms and be a flexion extension injury of the cervical spine. Brown's occurred, just one side of the cord's affected, so there'd be distinct ways to diagnose this. And then we already talked about Cohn's medullaris and coda equina syndrome. Anterior cord is usually secondary to an infarct, and it'd be complete plegia with preservation of the sensation. So what is a pediatric conversion disorder? So it's not as uncommon as you think. The lifetime prevalence of this is about 11 to 22 per 100,000 people. And this is sometimes seen in very young children who lack the capacity to verbally express emotional distress. So it's, at times a little bit more difficult to diagnose because some of this is normal in very young children. They can manifest physical symptoms from emotional distress. This is very different from malingering. So malingering is when you're purposefully doing this for secondary gain, either to get something or avoid something. But in a real conversion disorder, you are not aware that you're doing it. So it is very real to the patient, but there is no explanation. The symptoms or the deficits are not explained by a physical finding. Again, it's very important that this is the diagnosis of exclusion. So you want to make sure that you rule out everything that can be causing the symptoms that your patient is reporting before you dismiss it or diagnose them, rather, with a conversion disorder. This is a patient who came in with an acute onset of severe headache and vomiting. And looking at this scan, okay, well, what's wrong? So you see temporal horns. You don't usually see this in a pediatric patient. The ventricles are usually pretty slim. So you see that this is concerning for hydrocephalus. And then you see the fourth ventricle, you see something hyperdense there. So this is blood. Now we're getting suspicious, especially with this presentation. So the patient underwent a CTA, and sure enough, the CTA shows this collection of vessels concerning for an AVM. So how do we manage this? As before with hydrocephalus, we start by treating the hydrocephalus. So the patient received a ventriculostomy, and then the subsequent angiogram to evaluate the structure of the AVM first. Usually the diagnostic angiogram also includes the option to plug off some of these aberrant vessels or weak spots of the AVM if possible. And then if the AVM is not completely treated with the embolization, which is oftentimes the case, a subsequent resection of the lesion. In this case, also the patient received a ventriculoperitoneal shunt as the hydrocephalus did not resolve. So AVMs are not as common as aneurysms, but in children, they are more common. And if you have a patient who has an acute onset and a parenchymal hemorrhage, it's an AVM until proven otherwise. Most of the AVMs are diagnosed before age 40, and oftentimes the presentation is either a hemorrhage, seizure, sometimes headaches that lead to imaging. They are found. There is oftentimes associated weak spots in the AVMs, aneurysms. So 7 to 15% of AVMs have associated aneurysms. And there's occasional familial incidents, but they're not not like aneurysms. Aneurysms run in families, especially in the fins. But AVMs can be very much just sporadic. And here it says they cause 38% of all the intra parenchymal hemorrhages in patients who are between 15 and 45. So what is an AVM? So AVM is basically a connection of an artery to a vein without a capillary bed that would slow down the flow. So now all of a sudden the veins are receiving this high pressure, high flow blood, and after a while they become vulnerable for rupture, and that's how the bleeds happen when there's arterial pressure, blood flowing through a system that's not equipped to handle it. The AVMs, when they are resected, they can be resected without worrying about the tissue in between the vessels, because that brain is usually not functional and gliotic. So they are removed en bloc. So head trauma, that's probably the most common presentation of emergencies that we see aside the hydrocephalic problems. The head trauma that children have is less hemorrhagic contusions and more diffuse brain swelling and diffuse axonal injury. And why is that? The heads are large, weak cervical muscles. The texture of the brain is much softer as well. So there's a lot more damage to the brain, especially with whiplash type injuries. Shaken baby injuries can really do havoc on the brain tissue. And anyone who's operated on a very young brain knows that the actual texture of the brain is very, very soft. So it would be very difficult to suck out brain from a mature adult brain with just a suction, but the baby brain is very, very soft. So you can imagine that would be the case, that you have much more diffuse injuries. That's not as dramatic on a CAT scan. So oftentimes when we have a traumatic injury to a very young patient, the MRI is the gold standard to see the extent of the damage. Evaluating a head trauma, ABCs first, as naturally, and then neurological exam. Communicating coma scale is a little bit different with nonverbal children. There are pediatric Glasgow coma scales that are helpful, that allow us to evaluate even babies and communicate between teams. Decisions about whether the intervention is going to be medical or medical management or operative intervention. The goal of any kind of head injury is always trying to prevent the injury. So talking about helmets, car seats, but if that all fails, then trying to prevent secondary injury from cytotoxic edema causing increases in intracranial pressure and subsequent damage to the brain. So we always try to decrease the secondary injury and restore the brain's energy balance. And how do we do that? We'll try to make sure that the blood pressures are adequate and the intracranial pressures are not elevated. There's a clearly demonstrated association between intracranial hypertension and poor neurological outcome or death. So there are other things that can also cause increased intracranial pressures, which we had talked about earlier, such as infections, bleeds, strokes, ischemic injuries, and hydrocephalus. And the increased intracranial pressure triad is easy to remember because it's exact opposite of shock. So in shock, hemorrhagic shock, you see blood pressures drop, heart rates trying to keep up, respiration rates trying to keep up. And in the intracranial hypertension crisis, you see the opposite. So the brain's trying to keep up by demanding all the blood pressure to the brain. So the blood pressure spikes up, heart rate decreases, and the respirations decreases. So what's the benefit of maintaining ICPs? Obviously, keeping the patient alive, avoiding herniation. Treatment threshold when we start getting nervous is 20 millimeters of mercury, even in children. And if the pressures are over 40 millimeters of mercury for a long period of time, that's associated with a poor outcome. There's a couple of kind of classic things that you see. So here we have a subdural hematoma. This lens-shaped hematoma here is an epidural hematoma. we have a kind of a combo of two. We have some subdural blood. We have an intraparenchymal hemorrhage here. This is a cartoon of different herniation syndromes when we start seeing the brain being pushed on the wrong regions because of a mass lesion here. So this would be a transfalcine central uncal foramen magnum herniation. All that is bad. Sometimes not so easy to see. So this is a teenager who came to the emergency room after an injury about 3-4 weeks ago. He said he was playing basketball and bumped his head, was having some headaches, and then really started getting bad headaches, was taking ibuprofens, was taking 4 or 5 ibuprofens a day, and finally couldn't take it anymore, was vomiting, came to the emergency room. So this is the first CAT scan, and first glance you look at this and it doesn't look so dramatic, but you can see that there's asymmetry. So this side looks different from this side. So what's going on here? And MRI is very helpful here. So we can see that there's actually quite a large subdural hematoma, but it's not acute and it's not chronic, so it's almost the same color as the brain. So the patient underwent a burr hole drainage and did well, but again, it can be easily missed if you're not paying attention. So if there's a mass lesion, we always consider evacuating that, but sometimes that's not the case. So if there's a problem that's more diffuse to the brain, and we have to try to reduce the pressures, there are methods that we can use. So first, placing some kind of a monitor so we know what's going on. The options that are optimal is a ventricular drain, because you can monitor and treat increased intracranial pressures, but if sometimes that's not possible if the ventricles are very small. So a little catheter, that little probe that goes into the brain tissue itself, can give you readings. So that's an intracranial pressure monitor. Then we can use hyperosmolar therapy, so hypertonic saline, sometimes diuretics, and we can also increase sedation of the patient to allow intrathoracic pressures to allow better venous drainage, and sometimes that can help with intracranial pressures, and making sure that the patient is optimally positioned. So 30 degrees head of bed seems to be the sweet spot on making sure that there's enough perfusion and venous drainage to support the both the perfusion and the drainage. Making sure that the head is midline. So if you have a trauma patient, sometimes they will slump to the side. One jugular vein is obstructed. That can increase the pressures quite a bit. So when you get a call from a nurse saying that the ICPs are going up, that's the first thing you want to do, is you want to make sure that the collar is not too tight and the head is placed nicely midline. So if all else fails, we take off some bone, and we also open the dura, so decompressive craniectomy. Seizure prophylaxis. For any type of head injury that includes any type of blood in the brain, subdural blood, not necessarily epidural, intraparenchymal blood, there's evidence that early anti-epileptic use decreases the incidence of late epilepsy. So we treat patients with head injuries for 7 days with either Dilantin or most commonly with Keppra. And there's actually some evidence-based recommendation that this is helpful. So if surgery is needed, with children, there's considerations that can be pretty tricky, especially when it comes to the size of a child. So the total blood volume of a person is usually can be easily calculated by estimating about 75 to 80 mLs per kilo. So if you have a 6 kilo patient, that's not a lot. That's only about a soda bottle worth of blood. So you have to be very cognizant that you initiate blood transfusions early if you estimate that there is either already a lot of blood loss or there's going to be significant blood loss during the surgery. You also want to normalize the coagulation parameters as much as you can. Sometimes that's not an option. So there's a couple of cases that were hair-raising that we saw here at St. Chris, and there's actually 2 patients that came in the same time within 30 minutes from each other, and that's why it's helpful to have a partner, because I was able to call Atom to come in, and we were in adjacent operating rooms taking care of these patients. So this was a 5-month-old who had fallen off bed, hit a laundry basket. Mom noticed some swelling of the scalp and took him to the outside hospital. The outside hospital was not able to get an IV access and transported the patient over. They had tried to put in an intraosseous line without a success. So patient declined neurologically, was emergently intubated, and then this is the CAT scan. So this is pretty scary. You see most of the brain is pushed to the left. You have this ginormous epidural, and you see this dark spot here. So this is concerning that there's active bleeding happening. 3D reconstruction of the CT shows that there's a fracture that just happens to be in a spot that hit an artery, and massive bleeding is going on. So this child is only 5 months. Probably 30% of their blood volume is already in this epidural. That's why the hospital had such difficult time obtaining an IV line. And we did too. So after multiple attempts, I called the general surgeons to come do a cut down. But because of this scan, we couldn't really wait. So we ended up going to the operating room with a hemoglobin of 6 and a platelet count of 7. So simultaneously, the general surgeons were doing a cut down and starting a massive transfusion protocol, and the craniotomy was happening. The weight of this patient was 6.8 kilos, so his total estimated blood volumes was only about a Coke bottle. This is a couple of days later. The patient continued bleeding, so we continued the transfusion protocol for a couple of days with a drain that stayed in, and then finally the coagulation factor started working, and the drains were able to come out, and the patient made a full recovery. So while I was in one room, Atom was in the other room with a 3-year-old male who was run over by a hit and run. Patient was GCS 3 on arrival. Pupils were fixed in 4 millimeters. Hemoglobin wasn't much better. A little more platelets. Same thing, blood and platelets transfusion was started, and the patient was taken to the operating room. Here you see that there's also this dark spot here, so there's active bleeding going on, and there's a bilateral fracture transferring from one side to the other. This patient also had a laceration, so one of the bone fragments had gone into the brain, but after surgery, things were looking pretty good, and the patient made an excellent recovery. The biggest thing with both these cases was getting them to the operating room quickly and making sure that we had the blood ready and transfusions happening aggressively. About 30 to 40% of patients who succumb to trauma are basically it happens because of bleeding. So it's really, really important to start the transfusions early, because the patients can become coagulopathic and then you can't stop the bleeding. So if you is estimating that there's going to be more than 50% of blood volume loss, it's really crucial to get the blood bank and everybody on board to have the proper transfusion protocol started. You can't just give blood, you have to give also other products, such as FFP and platelets. Otherwise things don't turn out well. This is another patient, but I think we are getting short on time, so I'm just going to stop here and allow some room for questions, and thank everybody, of course, for joining me this morning.
Hey, Tina, thank you for that review. It's incredible when you sort of collate all that and put it back together, and to see the range of things that we've seen at St. Chris. Unfortunately, of course, when we say that we see all these interesting cases, they are people, but I think they're very lucky to have you. Now, one curious question that I have is that on the adult side of the world, there are some innovations and things that we do that make neurosurgery a little bit better and easier and better outcomes. Is there anything in particular that you're very excited about with regard to peds, whether it's trauma or tumor or anything that you might want to share with us that you think is going to be kind of changing the way pediatrics gets practiced?
Well, I mean, I think there's been some new things happening in the realm of hydrocephalus that I'm excited about. There are some new innovations in terms of treating hydrocephalus, and new types of shunts that are coming out. So I think things are probably going to be changing in the next 5 years in that era, and I think we've gotten better at treating trauma patients. In terms of anything dramatic, I can't really think of anything else.
Okay. Well, I mean, it's an incredible array of things that you see in your practice, from vascular to trauma to tumor to even that spine case, which was really quite incredible. So by telling us that there's something new in hydrocephalus, I think we have you now on schedule for giving us that update in hydrocephalus. Tina, thanks for taking an hour of your time and helping us learn about pediatric neurosurgical emergencies. I'm going to thank everyone else for being on as well. Please look in the comments for the EADS code, and have a good Friday and a good weekend. Take care, Tina. Bye-bye.
Bye.